All right, welcome everybody. We're starting on a weekly session on Virtual Global Spine Conference. This week we have a friend of mine, Rodrigo Amaral. He's a spine surgeon from Sao Paulo, Brazil. He's a distinguished leader and pioneer in the field of spine surgery in Brazil, particularly in the development of techniques focused on lateral surgery. So he will be talking about the history or the evolution of lateral spine techniques from the beginning to the more current techniques. So welcome, Rodrigo. I'm very happy to have you.
Thank you very much, Alfredo. It's very nice to be here. Thank you for your kind invitation. Let's talk a little bit about it's impossible to talk about the evolution and the new perspective of lateral surgery without going through the history itself. So I will give a brief introduction on the history and all the achievements that we get with the technique over time. And it's a big pleasure to be part of this initiative, the Virtual Spine Conference. And it's very good to be among friends, and you as my friend for many years, very kind friend for many years, invite me to be in this position, and I'm very grateful. Thank you very much. I'm seeing here a lot of friends, some fellows. I want to make clear that if anybody have any question during the presentation, just feel free to ask the questions, and I will try to be a little brief so we have some time for later on discussions if anybody wants. So let's start sharing my screen. Is okay?
Great, yes.
No, perfect. Let's see. Now, okay, so I'm Rodrigo Amaral, orthopedic surgeon from São Paulo, Brazil. I'm now director of the IPC, Instituto de Patologia da Coluna de São Paulo. I'm also part of the spine department at the Vita orthopedic group in São Paulo, founder of the Brazilian Spine Study Group, and Mude a Curva, what means change the curve, is an outreach program that help people with scoliosis waiting on the waiting list for scoliosis surgery in the public health system in Brazil. And I'm very glad to be here talking about the history of my life in spine surgery. What is the lateral spine surgery, the lateral fusion for spine surgery? Working for many years with Professor Pimenta here in São Paulo as my partner and also my mentor. And lateral surgery is being part of my whole history in spine surgery. So I want to start with this quote. Dean Kamen is the inventor of the Segway, the vehicle, the wheels that moves with the body balance. And he said that every once in a while, a new technology, an old problem, and a big idea turn into an innovation. And this is exactly what we face when we look at the XLIF evolution, is an innovation. And it's not easy to innovate. Innovate is a creation, development, and implementation of a new product, process, or service that aims to improve the efficiency, effectiveness, and competitive advances of old procedure compared to an old procedure. Innovation also needs to be, we need to be able to test and measure the efficacy of this innovation. So what we cannot measure, we cannot manage. The only way to learn is from what we measure. So innovation is always a win-win situation. We never lose when we innovation, because we either learn with the failures or we succeed. So Every time we have a failure, we have to come back to the basis and ask questions. So why is wrong? What I did wrong? What I could done to make it better? Every time we succeed, we have also to come back to the basis and ask the right questions. What I did to make this right, and how can I apply this type of learning to other projects, and how can I improve this even better? So it's a continuous process. It's not a only idea. It's a combination of idea with persistent working that have to come back to the basis every time. So talking about the evolution of the lateral approach is absolutely necessary to understand the basis of this procedure. And everything starts in the late 90s when John Reagan came with a paper about a new approach to the lateral to the lumbar spine, and he's using at that time video-assisted laparoscopic video-assisted retroperitoneal approach for the lumbar spine. And early in 1999, Dr. Pimenta started to do this type of approach here in Brazil, and get some experience with the three-portal, doing the dissection of the retroperitoneal space with a CO2 balloon, and trying to use the endoscope for reaching the lumbar spine and crossing the psoas muscle. And at that time, he's using the BAK cage. For those who knows what the BAK cage used to be a cylindrical cage that threaded into the disc space. And back in the 80s and 90s, this would be a standard procedure for the interbody fusion. And most of the complications at that time was related to the stability of that implant, and also the complications with how hard was to manage a camera inside of the retroperitoneal space with a three-portal, triangulating instruments inside of the belly of the patient and trying to cross the muscle with a safe working channel. So very fast, Dr. Pimenta realized that the video-assisted and the three-portal access to the lumbar spine, to the retroperitoneal space was not very easy and was not very effective. And then he came with the early days of the lateral approach, what he calls lateral endoscopic transpsoatic retroperitoneal approach. And that was kind of a same endoscopic procedure, but with just one portal and guided to with the finger. So the dissection of the retroperitoneal space was done with the finger inside of the retroperitoneal space, creating this space, and then using guide wire and dilators to cross the muscle with the video assistance of the endoscope. And he can reach the spine. He could implant good size interbody spacers. As you can see here in the examples, most of the spacers, they titanium spacers at that time, and most of the spacers, they settled down, and the subsinus rate was almost 100% with this procedure at that time. But he could learn with this experience and understand that it was possible to go inside of the retroperitoneal space and reach the spine from that type of approach. So the key idea at that time will be how to avoid critical structures like the retroperitoneal content, ureter, also how to manage the psoas muscle and the lumbar plexus inside of the muscle, trying to keep this as minimal invasive as possible. And that time he's using endoscopic view to do this type of approach. The possible advantage of using this approach will be allowing larger implants and less morbidity for the surgery, avoiding posterior open approach, and trying to keep this as minimal invasive as possible. What is the problem that he have to face at that time? So it's not easy to cross the psoas muscle without damaging the lumbar plexus, because as we know from anatomy, the lumbar plexus is seated inside of the muscle, and it's almost impossible to define exactly what is the point of crossing this muscle without damaging the nerve. Doesn't have the industry doesn't have any good size implants to cover from cortical bone to cortical bone, and he's using at that time a 2D visualization endoscopic assistant. So that's the scenario that he faces for creating this lateral technique. So the old problem, it would be assessing the lumbar spine, small implants, and 2D visualization. The new technology merging at that time would be the self-monitoring, self-assessment EMG, trigger EMG that can be used integrated with this type of procedure. And as many companies were going to less invasive surgery, a lot of different types of retractor system was being developed to addressing spine problems. So the big idea was integrating those two new technologies, EMG and retractor system, to full planned and comprehensive procedure. So the plexus monitoring at that time could be done using this triggered EMG, increasing safety for crossing the psoas muscle, custom-made large implants that can cover from cortical bone to cortical bone, also integrate the platform of XLIF, and he moves from a 2D visualization endoscopic assistant to a direct visualization with integrated lights into the retractor system. So in 2003, XLIF comes to the market with the combination of these three different features: a old problem, two new technologies, and the big idea of crossing unusual corridor to the lumbar spine, and being able to reach the lumbar disc from lateral to lateral, orthogonal in a safe manner, and being able to put the larger implants that we can use in the lumbar spine. So XLIF come together as a combination of out-of-the-shelf 3-blade retractor, a piece of plastic, and integrated light with directional neuromonitor. So wasn't a very big development itself, but it was a very good innovation for the future. Very basic development at that time, but very big innovation. So the first publication in English language of the XLIF technique was in 2006, but the first publication of early experience happens in Brazil in 2003. So 3 years after we start our cases here, he did the first publication on the technique itself. And even in 2006, he was expanding the indications for more complex applicabilities, like we can see here in the publication of Charité revision retrieval of a Charité disc, artificial disc through a lateral minimally invasive technique. And over time, these indications evolve a lot, and we're going to talk about this later. So the rise of XLIF over this 20 years of history so far, from 2003 to 2023, passed through many different challenges and face a lot of controversy in the market, and also bring many answers to all of the criticisms. And over 20 years, we can say that this is a very well established technique and have space for grow, and also stands as a standard technique for many of the surgeries across the world. So the three bases of the technique itself is using the largest footprint implant that you can use in the spine, is even bigger than an ALIF because cross from lateral cortex to lateral cortex. So this large footprint increase not even the exposure of the disc space, increasing fusion rates, but also provides a very stable biomechanical construction that helps with fusion. XLIF also increase the height of the disc space and keeps this height over time. So creates the ligamento-taxis correlated with the indirect decompression. And this is one of the phenomena that we can see in this technique that mimics the same concept that we can use, that we use for many years in the cervical spine, applying indirect decompression to the foramen, distracting the ligamentum flavum, the posterior annulus, reposition the disc space in the previous position, and this can provide indirect decompression to the neural elements. And all of this can be done to a minimally invasive approach, sparing muscle damaging and speeding the process of rehabilitation. So one of the key concepts of the technique is the indirect decompression. The first paper on the indirect decompression was published by our group in 2010. And after this publication, many authors try the same methodology, and they also prove the efficacy of the indirect decompression in the practice. And now we can say that indirect decompression is not a debatable concept anymore, and most of the surgeons, they really accept the concept of indirect decompression in the lumbar spine as a standard technique. The publications on this technique evolve over time, and you can see exponential number of publication over time, and we reach almost 400 publications last year, as you can see in this graphic. And this continues evolving, especially now with the new technology integrated to the lateral technique. Actually, the first paper, the original paper, the description of the technique itself was quoted as the most cited paper on 2017 for the Spine Journal on the section of minimal invasive surgery for the Spinal Journal, and also the Spinal Journal published a specific issue only focused on lateral spine in 2017, showing the importance of this technique for the scientific community. Indications of this procedure is very variable and can start with very simple cases like degenerative disc disease, recurrent disc herniation, patients with spinal stenosis with no deformity. And you can see here that this can be handled in a very minimal invasive fashion, very stable construction with or without posterior fixation and supplementation. But this can achieve very good results in a very minimal invasive fashion. Also, a very good indication for this technique is for adjacent level disease. Adjacent level disease is a hard condition to treat because it's not only correlated with a transitional level over a previous fusion, but it's also correlated with sagittal imbalance issues, and being able to use a less invasive technique for restoring disc height and also creating lordosis is an important tool to help this type of patient. Most of the time, if we're dealing with adjacent level disease, we facing a patient with a sagittal imbalance, we can use more lordotic implants, and most of the time we need to supplement this with pedicle screws. But it's also possible to treat simple adjacent level disease as standalone fashion, especially with larger implants and integrated with lateral fixation systems. So this is also a very unique and very interesting indication for this surgery. Spondylolisthesis is definitely one of my favorite indications for this procedure. Spondylolisthesis is a very hard problem to deal with. It's a common problem for many for all of the surgeons. It's a common problem in the office for many of the spinal surgeons, and sometimes it's hard to deal with these cases because we have significant narrowing of the disc space. We have a very compressed condition in the neural elements, and being able to restore disc height and also to translate the vertebra to the original position allows you to create a very stable construction, restore lordosis, and also indirect decompression of the neural elements with a true MIS procedure. And you can see here that it can achieve a significant amount of lordosis correction and also translation. And the concept of indirect decompression helps you to preserve posterior elements and not being necessary to do an open laminectomy and exposing this patient to risks of inflection and blood loss and more trauma to this contraction. So you can see that it's possible to achieve very good results only with indirect decompression, as the MRI show in the bottom. This is a true MIS procedure, and you can achieve a significant amount of indirect decompression and patient satisfaction over time. As we expand the technique for more complex cases, we also expand the use of the lateral technique for deformity patients. And we start to do constructions with patients with the spine deformity in general, but we start to do actually for patients with adult spine deformity, degenerative scoliosis. And we realized that the use of multiple interbody spacers in the apex of this deformity not only allows us to reconstruct sagittal alignment, because we can restore disc height and also lumbar lordosis, but helps the control of coronal malalignment and also axial derotation. So a lot of papers, a lot of authors and surgeons start to use this technique for as a MIS procedure, or combine it with posterior approach for treating degenerative scoliosis. And we can see the applications for this even for mild or moderate scoliosis cases, like you can see here in the examples, or more complex cases when you have a significant malalignment, spondylolisthesis, lateral listhesis, and a significant need of lordosis restoration. So it's a very versatile technique that can be applied not only for mild and moderate degenerative cases, but also can be applied for more complex cases, combined with open posterior approach, achieving a very significant restoration of lumbar lordosis and amazing ability to flexibilize the spine and control scoliosis correction and also coronal alignment. As we expand this technique for upper levels, we expand the lateral approach not only for the lumbar spine, but also for the thoracic spine. And many applications for this technique on the thoracic spine is possible. One of the beautiful applications of the lateral technique is for the thoracic disc herniation, especially for the gigantic calcified thoracic disc herniation. And the literature is full of papers on this topic, especially the papers come from Dr. Uribe Center. Most of you know Professor Juan Uribe and have a special interest on this topic and a lot of experience. And he put together a very didactic paper on how to approach the thoracic spine, how to do a retropleural approach, and how to reach the spine through a less invasive minimal mini thoracotomy, dissecting with the finger and releasing the pleura from the chest cavity and creating a retropleural approach, what allows you to reach the spine without having the problem of dealing with the lung, selective intubation, reducing the risk of complications in the chest cavity, and being able to address most of the anterior pathologies on the thoracic spine through a direct access under direct visualization and with a very effective way in a less invasive fashion. So it's possible to do open thoracotomy with all the benefits of a direct visualization to the thoracic spine with a less invasive approach. And this can be applied not only for thoracic disc, calcified thoracic disc herniation, but also can be applied to tumors and traumas. So here you can see another the same indication, but also for larger decompressions. As you can see in this case, a huge compression. This patient had a severe myelopathy, and I decided to do a full corpectomy at the level of the compression with the total release of the disc space with no remaining compression and no significant complications for this approach. But you can also use for trauma, acute or chronic trauma, and you can perform very strong fixation, anterior fixation, because you can use long end plates that settles on that holds on the cortical bone and can achieve very good results on reduction without facing a lot of subsidence. And this can be done combining an anterior approach and a percutaneous fixation with very efficient results most of the time. Here you can see a different application of the ACR technique. This is a heel compression fracture causing acute kyphosis on the thoracolumbar junction. And we did a ACR here, hyperlordotic interbody spacer to compensate the kyphosis of the disc space and a segmental fixation, restoring the perfect anatomy of the thoracolumbar junction with a very small, less invasive procedure, much less invasive than a 3-column osteotomy at that level. So another application, a beautiful application, elegant application for this technique is for revision surgery. And you can consider revision surgery, pseudarthrosis for posterolateral fusion, also T-leafs and PLIFs, posterior fixation that doesn't heal. So you can remove very easily any type of interbody space from a lateral approach. But it's also possible to revise total disc replacements, especially because the risk of a total disc replacement, the revision risk of a total disc replacement for this from the same approach is to face all the adhesions of the great vessels into the disc space. So using alternative approach is always a benefit to the patient and also decrease the risk of complication. So here I bring some of our cases, a 2-level total disc replacement that fail in L4-5 and start to develop a progressive spondylolisthesis with the breakage of the core of the charité disc replacement at that level. And we did a revision from a lateral approach using a hyperlordotic implant at that time, fixating with a integrated screw. And this patient could, find a good amount of lordosis correction because this patient have a hyperlordotic spine, and we mimic the lordosis of the spine in a beautiful way, and we could revise this without facing all the scar tissue and the adhesion of the great vessels and the anterior part of the L4-5. Also, the second case is pseudarthrosis of posterior fixation, a T-leaf that doesn't heal with adjacent segment disease, and we are able to do a revision of the loose implant, the previous loose implant, and also treat the adjacent segment disease with only one minimally invasive simple approach with good results. With when we start to do deformity, we start to face patients with severe malalignment, severe kyphotic lumbar spine, and then we start to wondering how we can manage lumbar kyphosis with a less invasive approach from anterior elongation, and then we came up with the idea of the ACR, what is the hyperlordotic interbody spacer that can create lordosis without having to compress and without having to shortening the posterior spine. And the ACR becomes very popular for many of the deformity patients because most of the time you can reach a significant amount of lordosis if you combining this ACR, this anterior elongation with posterior shortening, and we can reach 20 and 30 degrees of lordosis with this technique. without having to expose the patient to the risks of posterior three-column osteotomy. So the literature shows if you have the ability to plan your ACR and put the apex of the lordosis in the right spot, use this as a combined procedure, you can achieve very good results, even for severe sagittal imbalance patient using these hyperlordotic implants at the anterior spine. So there's a lot of data in the literature showing the capability of this technique to restore lordosis, and this can be done in a minimum invasive fashion or combined with a posterior hybrid approach. We also use combination of the lateral technique with A-lifts, so we can handle very hard deformity, iatrogenic deformity. If you combine the anterior approach with the lateral approach, it's definitely not possible to reach L5S1 through a lateral approach because of the anatomy itself, the position of the iliac crest, the position of the vessels, the anteriorization of the psoas. But if you can combine anterior approach with a good lateral approach and good planning, you can achieve very good results with the anterior elongation techniques. And we can apply also for a very severe deformity, as we can see here, a patient with multiple previous surgeries, with a collapsed kyphotic cervical lumbar spine, unable to walk, cerebral palsy, a previous walker. So this patient is a very severe and sick patient, and we are able to combine anterior approach with a posterior fixation with multiple rods and extension to the ilium with a very good result, restoring standing and also capability of walking of this patient. What do we have to expect in terms of complication with the lateral approach? So the most common complications comes with the plexus, the lumbar plexus. It's important to understand the correlation of the lumbar plexus and this technique. It's important to understand that the lumbar plexus stays inside of the psoas muscle, and we're crossing the psoas muscle. So we need to handle the lumbar plexus without seeing the lumbar plexus. So we can use neuromonitoring, you can use EMG, you can use SSEPs, you can use MEPs if you're doing a multimodal approach, a multimodal neuromonitoring. But it's very important to understand where the lumbar plexus cross the psoas muscle and the correlation of the lumbar plexus with different levels. So many authors publish experience and papers and cadaveric analysis and clinical experience, trying to understand in a good manner the position of the plexus regarding the disc space on different levels. And over time, we kind of establish a safe working zone for many levels, especially important for 4, 5 level. Most of the time, the 4 or 5 level, the working zone will be right in the center of the disc space. And usually you are able to expand your dissection through the anterior cortex of the disc space and place a good size implant crossing from side by side and stabilizing the spine. And it's very important to understand this to prevent sensory and motor complications on this level. Ali Baji published this paper doing a review on anatomy, and after the full understanding of the anatomy, we can see a significant increase on the adoption rates of this technique for many of the surgeons all over the world. A lot of people talk about neurological complications with the lateral approach, but in fact, when you go to the literature and see the systematic review and the meta-analysis, the real deficits, the incidence of real deficits is very low, usually around 2.8 to 3% of femoral nerve pulses and quads weakness. But of course, we cross muscle, and we have to expect it by just by crossing a muscle, we have some side effects. And even now, 20 years after the publication of the first experience, is not well established in the literature. What is a complication for this technique, and what is only a side effect of crossing a muscle? Because most of the people say that psoas weakness will be a complication, but if this happened right after the surgery and solves within 3 weeks to 12 weeks, this is actually just a side effects of dealing with a very important muscle for the gait, because the psoas muscle is important for the hip flexion. And we have a lot of inhibition of this muscle after we cross this muscle. So after a full understanding of what are we dealing with, and understanding what is a real neurological deficit, we face with a very low instance of complication, real neurological complication with this technique. What about major complication? We're dealing with abdominal wall. So we're dealing with like an anterior-like approach. So we have to be able to manage major complications like bowel injury, like vascular injury. And as you can see here in this timeline, since the beginning, the lateral adopters, they decide to put together a community to honestly debate on the indications, the evolution of the technique, and also collecting data on the complication. And for many years, the SOLA Society stand together as a community of lateral surgeons specialists. And in 2010, one of the publications in the literature showed one bowel injury over 8 cases, with a 12% in that series of bowel injury. And in 2014, a fatal vascular injury was published. And until that time, the reports of severe major complication was just anecdotal reports in the literature. But that fatal vascular publication puts together a red flag on this topic. And then we decide to stop all the experts. We'll put together all the experts and collect real data on major complication. And then in 2015, Dr. Uribe put together a survey with 77 experts on the technique, with more than 100 cases experience, collecting 13,000 cases, showing that the incidence of a bowel injury was 0.08%, and the incidence of a vascular injury was 0.1%. So probably this is lower than the risk of a vascular injury through a posterior approach itself. And we know that we can damage a vessel through a T-leaf approach. We did this, we collecting not major, we call major complication vascular and visceral complication, but also wound infection. And as we do dealing with a minimal invasive technique, we can see that infection is not a big problem for this type of surgery, because we're not damaging the muscle, we're not doing a very aggressive work with for the disc space, and we're not denervating the posterior muscle, preserving vasculature and innervation. And the overall rate of major complication stands in 0.5% or to 0.7%. So it's a relatively low rate of complication, and we can say that this is a safe procedure in general. The contraindication for a lateral procedure will be definitely 5-1. 5-1 is a no-go. The anatomy on the L5-S1 level doesn't allow the surgeon to reach the spine in this position, not just because of the iliac crest, it stays in the way, but also the vessels, they position more lateral, and also the psoas muscle and the plexus goes more anterior, blocking the lateral access to the L5-S1 space. But also, if you're dealing with a 4-5 transitional anatomy, you can face the same problem as you face in this L5S1. So anteriorization of the psoas, anteriorization of the lumbar plexus, lateralization of the vessels can be a contraindication for sure. Also, patients that have extensive abdominal retroperitoneal approach, they can have scar tissue in that position, and this doesn't allow you to create a safe retroperitoneal space. And some abnormal distribution of the vessels can also be relatively contraindication for a lateral approach. So, but for over L4, L4-5 is usually ease technique and a feasible technique in a very safe manner. The evolution of the implants itself, we came from side-by-side coverage from 50 to 60, 45 millimeters lateral to 60 millimeters lateral to lateral. And we start with the 18 millimeter anterior posterior, increasing to 22 millimeter anterior posterior, and also to 26 millimeter anterior posterior. And the three sizes pretty much fits 99% of the population, the body sizes. So when we move from 18 millimeter cages to 22 or 26 millimeter cage, we realize that the incidence of subsidence in a standalone fashion drops dramatically in our series from 30 to 10%. So we understand the importance of the biomechanical construction that this large footprint can provide you. So it's important to understand that the benefits of the technique relies on the biomechanical. But we also expand the type of implants that we use, not only for degenerative cases, as I mentioned, the ACR for deformity cases with 20 and 30%. We also expand the use of the lateral access for corpectomies in the thoracic spine and the lumbar spine. In the past, we did a FDA trial on TDRs, lateral TDRs, that doesn't go through because of the metal-on-metal surface, but it was a very good experience at that time, and we have some patients still with no problems with this technique. And right now, with the evolution of the technology itself, we can see like 3D printing and also porous surface of the implants and also expandable technology. The retractor itself evolves over time, starting with a specular, 3 blades altogether, open altogether retractor, and then we move to a 3-blade retractor with integrated 4-blade optional retractor. Integrated lights, some companies use 4-blade retractors, some companies use integrated lights in the blades, some people want to use the microscope. There's many different types of doing the approach itself, but most recently we're using a solid 2-blade retractor for stability that provides us a rectangular opening of the disc space, more limited access to the psoas muscle, reducing the damage of the muscle, and also increasing stiffness of the retractor and stability, especially for prone position. The neuromonitoring system also evolved over time. And we start in 2003 with the Trigger EMG. Now we have integrated self-assessed SSEPs, and we start to talk integrated self-assessed MEPs as well for the future. So neuromonitoring also evolved, bringing more safety and more reproducibility for this technique with more options for neuromonitoring. So the name of the technique and the description of the technique also evolve over time. So we start in 2003, 2006 with the first publication with the name XLIF. And then some companies came with the direct lateral, what the literature used to call DLIF, that evolves to a oblique anterior to psoas approach, what we all know right now as a OLIF technique. But in the late 2017, 2018, the scientific community start to talk about single position surgery, and they start to discuss about how much time we used to lose in a surgery just by positioning the patient in a different position, taking the patient from the lateral position and putting the prone position for the screws. And then all the scientific community, with the advantage of the navigation, they start to talk about single position lateral surgery. So single position lateral surgery stands as a viable and good option for degenerative cases. But analyzing the data on the lateral axis itself, we can see that almost 75% of the US surgeons, they was trained on lateral technique, but only 20% of US surgeons, they adopt lateral surgery as a gold standard for lateral fusion. And then the scientific community start to question if the real problem was the position of the patient itself in the lateral position, and not only the flips. So we start to consider doing single position surgery, not in the lateral decubitus, but also putting the patient in prone position. So in 2020, Lamartina and Berciano, they published the first experience with the prone position for lateral interbody fusion, what they call pro-XLIF, with the preliminary results. And at that time, they faced a lot of complications handling the weight of the retractor itself, the mobility of the retractor, and how to stabilize the three-blade retractor in the prone position, because the gravity was acting against you. And then in the same year, Pimenta and co-authors, they came together with the prone transpsoas technique, what is the evolution of the prone, the pro XLIF, with a special design, two-blade retractor, patient positioning, and trying to solve all the difficulties that the previous authors face with the experience. So more recently, we adopt the prone position as a standard for our lateral surgery, and we're not doing lateral access to the lumbar spine in lateral decubitus anymore, just for very selected and specific patient. But we using prone transpsoas as a standard technique for our lateral access for 4 years now. So we realized that turning the patient to prone brings a lot of benefits, not only for the workflow, but also for the surgery itself. Prone position is a very lordotic friendly position, is a very familiar workflow for many of the spine surgeons. We can also combine your lateral or your anterior spine work with posterior decompression, osteotomies, and you can also combine it with deformity correction. And this is becoming a very powerful and strong tool for many indications over here. So I can put some benefits here. Here is one of the surgeries that I did live broadcasting to US. And you can see here that I did a deformity correction with an open posterior approach, with a lateral access after positioning my screws, doing my facetectomies, doing my posterior release, and then coming back right away to the posterior approach to finalize final tuning my lordosis and doing my final construction with the rod. So I can say that this position is very lordotic friendly, and also position the patient in a Jackson table with extended or neutral hips, brings the psoas muscle more posterior, and also the lumbar plexus more posterior. Using special bolsters with coronal bending allows you to reach our L4-5 level and also L1-2 level in a more efficient way. is a very good technique for spondylolisthesis reduction, because the gravity helps you to reduce the spondy, and also allows you to go posterior and anterior at the same time. And you can do, of course, you can do any type of posterior approach at the same time and as you doing your lateral access. You can even work with two surgeons, one doing one part of the surgery at the same time. So this is some of the studies that we did trying to understand the effect of the patient positioning on the psoas muscle and the lumbar plexus. And here you can see one of the papers that I wrote proving that the psoas muscle moves more anterior in lateral decúbito, exposing the flexure to a more dangerous situation. And here on the right side, you can see Aluri and Shira Qureshi papers that they did a cadaveric dissection and putting some markers into the lumbar plexus, proving that extending the legs in prone position can bring the psoas muscle and the lumbar plexus more posterior, allowing you to reach L4-5 level in a safer way with a better working zone. Also, the lumbar lordosis, not only theoretically, you can prove this with the clinical experience. Our early experience with this technique and comparing our data with the previous data that we achieved with the lateral position, we can see that we can improve segmental lordosis from mean 1.9 degrees to 6.6 degrees. Also, a multicentrical experience show the improvement of segmental lordosis can reach 10 degrees or more, what is a very good number for average degenerative cases for the lumbar spine. Here you can see the effect of the prone position for the lordosis restoration. Here the preoperative imaging with the patient standing, and also intraoperative imaging with the patient in the Jackson table when extended legs. We go from 4 degrees of segmental lordosis in L3-4 level to 12 degrees, and we finish with 17 degrees after the position of the implant and fixation. So the gravity and the position itself helps a lot for you to restore segmental lordosis for this type of patient. Using the special bolsters that allows you to bend the patient coronally, not only provides a better lordotic work frame, but also helps you to clear the iliac crest from your way, so you can reach L4-5 level in a safer and more reproducible way, and also you can reach 1-2 level in a safer and more reproducible way. And actually the coronal bending tools, the coronal bending bolsters, positioners, they help with scoliosis correction and can be a powerful tool for long and complex cases as well. Here you can see the effect of the position on the spondylolisthesis. On the right side, just by positioning the patient, you can see a very mobile spondylolisthesis reducing 100% and creating a lordotic segmental disc space. And on the right side, you can see a combined posterior and anterior approach when the surgeon decides to do a pedicle fixation, position the rod, partial reducing the spondy with a gentle maneuver, then moving to the anterior approach, doing the disc space preparation and positioning the implant, and then finishing with a final reduction of the rods and completely translational reduction of the spondylolisthesis. Here is another study comparing lateral position and prone position data. This is a multicentric a single center propensity score matching analysis when they are where John Polina put together the group two identical groups and compare the amount of lordosis restoration, and you can see from 0.5 degrees in average to 9.9 degrees in average, comparing these two techniques. So we can say that this is a very powerful technique for lordosis restoration, and a good option and viable option for lumbar fusion. Of course, it's a familiar workflow. Everybody is trained to do posterior surgery for the lumbar spine. So it's a very familiar workflow, not only for the surgeon, but also for the scrub techs, for the x-ray. We know that position pedicle screws in a lateral position can be done, but it's not a fun surgery. It's usually a lot of work for position the bottom screws, because the angle of the screws is going up and the patient is close to the table. Sometimes you have to deal with the pillows of the table. Sometimes the convergency of the pedicle screws is not so easy. And even when you're doing this under navigation, is not a fun technique. And also position pedicle screws in a lateral position increase the risk of pedicle violation and increasing the risk of neurological deficits. So in my experience, I did this many times in lateral decubitus, but it's definitely my preference to do this in a prone decubitus and with the patient standing in a Jackson table. As we know, most of the lordosis that we can achieve in the lumbar spine, especially when we're correcting a spine deformity, comes from the posterior work. Having the patient in a prone position helps you to do your PCOs and final tuning your lordosis to a more effective lordotic construction, especially considering the apex of the lumbar lordosis. It can bring the apex of the lumbar lordosis to the right spot, preventing superior correction and increasing the risk of PJK. As you can see here, if you have the patient in prone position and you can use also navigation, you can start with your posterior access, do your facetectomy, do your posterior release, position your pedicle screws, doing your lateral exposure, position your implants, and then coming back to the posterior surgery and doing rods and final compression. So it's a very effective way of doing a lateral surgery, and in my hands is being a standard technique for the last few years. We study also the risk of complications with this I will call new type of lateral approach. And the risk of complications sounds to be exactly the same risk of complications as the regular lateral interbody fusion. The average neurological symptoms goes from anything from 3% to 30%. But if you look at the risk of persistence in the femoral nerve palsy, would be around 2 to 3%. And subsidence rate would be around 3%. Wound infection also very low. 87% of the patient was discharged in day one, in post-op day one, and with 1.9% of readmission in 90 days. So I can say that this is a very predictable and very safe way of performing a lumbar fusion. What I expect for the future actually is not really the future, is actually the present of this technique itself. So we start to talk about surface technology, not only 3D printing, but also nano engineering for different types of surface, the surface of the implant that can induce bone growth to different size poros, or also the porosity of the 3D printing. Also the integration of biologicals with drug delivery, with anti-inflammatory peptides that can reduce the edema and the bone formation induced by the BMT2. We can also use stem cells or biological engineering for inducing bone growth. This is the future, not only for the lateral technique, but this is the future for all the fusion, the lumbar, the spine fusions itself. But I would say that the fusion for the lateral technique is the full integration of a platform that can use spinal navigation and also spinal robotics, reducing the gaps between surgeons' skills and delivering to the patient a more reproducible and more predictable results. So we are using some type of navigation, and we start to using first experience with robotics here in my country. I know this is a reality for many of the US hospitals, for a lot of US hospitals, but this is definitely not a reality overall the world. And I think the future for this technique would be a full integration of specific design tools integrated with preoperative planning, intraoperative navigation and robotic, and the post-operative reconciliation. So what really makes an invention is when someone decides not to change the solution to a known problem, but to change the question. And what lateral lumbar interbody fusion did and is still doing is to change the question every day. So thank you very much for the invitation. I'm open for questions. It was a big pleasure to be here.
Thanks, Rodrigo. It was an outstanding review of the evolution of lateral surgery. We're gonna go straight to the comments in order to respect the time. I know it's Alex there. If you have any question, please tune up. There's a question about the use of pins for L4, L5 spony to do distraction of the space, particularly for the risk of femoral nerve injury. Do you have any comment about that?
Use of what pins?
Pins like shrimps that goes like small screws that go through the bodies to do distraction.
Okay, yeah. So I have been part of the history of the lateral surgery, and we try pretty much everything for many years. So the evolution of the technique passed through many challenges, and we have the opportunity of using small screws or wires going into the disc space. And what you realize is that using a screw that goes into the disc space can provides a better stability, can increase the stability because it holds the retractor into the disc space, but also increase a little bit the risk of small bleeding of the bone and psoas hematoma. So if it's not something really necessary for increased stability, I will not recommend you to use a pin into the disc space routinely, because this can increase a little bit the risk of psoas hematoma. And most of the retractors in the market, they doesn't have the enough strength to increase disc space. I think disc space restoration is a process that is based on full disc space release and also sequential dilation, sequential trialing. So it's much more reliable to use broad discectomy and using trials, sequential trials, 4 millimeter, 6 millimeter, 8 millimeter, 10 millimeter trial to restore disc height. Then try to do this with the distractor, because you can even break osteophyte or creating a bone defect that can result in a hematoma.
Awesome. Thank you. Dr. Amaral, may I ask a question? Mamigani
sure.
Here from Switzerland. Do you switch completely to prone XLIF, or do you still do some lateral decubitus surgery? What is your percentage? How much do you prone and how much lateral?
I would say right now I'm doing 90% prone because of the benefits that I show in the presentation right now. I still saving lateral decubitus for standalone. I don't know, it's just my preference. I don't think it make a lot of sense to put the patient in prone position for a standalone, but it can be done. And also if you have like a corpectomy or you have some more work to do, I think lateral position can be a little bit more stable. Sometimes if I have like a 4-5-5-1, I do my own ALIF exposures. So sometimes I do my ALIF exposures in lateral decubitus. I do my 4-5 in lateral decubitus, and I do my posterior fixation in lateral decubitus. So I do a 3-6 construction in only one position, what I think is time saving. But also this is just for specific patients that not requires a lot of lumbar segmental lordosis. So if I doesn't need a lot of lordosis and the patient doesn't have a lot of deformity, and I do it in 4-5 and 5-1 construction, sometimes I decide to do this in a lateral decubitus.
Oh, thank you. And may I ask you, how many laterals do you do in a year? Is it like 100 to 2 per week? So just curious for my learning curve. I didn't start with prone. What is the amount we have to do it regularly to get into the flow? What is the number you recommend?
It's hard to tell because, first, if you have previous lateral experience with the patient in lateral position, is very easy and a straightforward technique. Probably within like 5 to 10 cases, you probably managing most of the situations. But if you have no experience with lateral surgery at all, the learning curve will be a little larger, will be a little longer, because you have to understand the anatomy, you have to understand how to manage the retractor, you have to understand how to manage the neuromonitoring, you have to understand how is the indications and contraindication for addressing, especially 4-5, because of the transitional anatomy, position of the psoas, vascular anatomy. So I would say a good number would be like 30 cases, and starting with easy cases and going through more complex cases as you get more experience. But there's not a magic answer. Depends on your background and your how comfortable you are with the lateral technique itself.
Thank you. It was a great presentation. Thank you very much.
Oh, thank you. Thank you.
Thank you again, Rodrigo. Was an extraordinary review of 20 years of experience in a pretty specific technique. So I really appreciate what you've done. And we'll see everyone next Thursday night for another weekly session of Virtual Global Spine. Thank you. Bye-bye.
Very nice, Alfredo. Thank you very much. Really appreciate the opportunity, and I put some compliments on the initiative of the Virtual Spine. It's a big pleasure to me to be here. Thank you.
Thanks.
Thank you. It was awesome. Thank you.
Bye.
Thank you. Bye-bye.